that I wanted to introduce to you this morning before we get started with our virtual journal club is the fact that dvm.com has been invited and allowed to beta test a new application, I guess you call it an application, from Facebook called Facebook at Work. And normally this is for businesses, and where you have actually a Facebook type of page where the business and the business employees can interact in that regard. And it's normally reserved for businesses, but dvm.com has been fortunate enough as a giant group of veterinarians to be able to participate in beta testing this. Now there will be, as of 2017, a fee, actually a nominal fee, but for the whole year we actually have access to it free. So Ravi has established various groups like a strategic working group and a medical case discussion group and yada yada various groups. And I've talked to Chris Perry, and he is going to actually spearhead a Facebook at Work group for you as interns so that you guys can do the Facebook thing among yourselves as a group. We may eventually expand it to interns everywhere. I've talked to my daughter in Edinburgh, and she's going to talk to the students and see if we can get a student group. I'm actually going to talk to the management at River and see if we can get a River group. So if you guys have any other ideas for types of groups to beta test this and you're interested in doing something about that, then let me know and we can put that together. But it sounds kind of fun. Facebook is kind of natural to everybody in your generation, and so I think it'd be pretty easy to use. The nice thing about this is the privacy is huge. It doesn't connect with your personal one. People on the outside that's not part of the at-work group can't see it. At any point, if you decide not to do it, the information can actually be scrubbed so that there's no invasion of privacy. It's not used for marketing or advertisements or anything. So I'm kind of excited about it. I've been playing around with it a little bit. And when Chris sends you the information about it, that's what it's going to be. And the only thing that's going to be required is that you have a dvm.com email address. That's also free to you, and it's fairly easy to sign up. So with no more further ado, we're going to try to conduct our very first virtual journal club. And the two articles that I had selected for you all were with respect to hemangiosarcoma and two different concepts. One, of course, is our conventional hemangiosarcoma survival times with and without chemotherapy. And in the chemotherapy group, it was with a doxorubicin-based versus a metronomic therapy. And I think what we will do is start with that one first. So you all have that one. It's out of JAVMA by Wendelberg et al. First of all, after reading this, I kind of wanted to know what everybody's impression was. Do you think it was a good study? Do you think it's a useful study? Does it have relevance? Let's just give some general impressions, and then we're going to go back through it on a structured basis. So does anybody have any comments?
See, before we get to our comments, I want to break in for a second. Is there a way you can turn it back on so that we can see your face?
Oh, well, that's interesting. I'm supposed to be screen sharing. I guess I have to turn the screen share off. Would you think that would be what we need to do? How about this? Does that show me? No. You can hear me, right?
Okay, we can hear you.
Okay. So where's my little Google bars over here? I'm working on it, you guys. You went away.
We can still see your screen.
Okay, you're back. Can you see me yet?
Not yet.
No? Okay. Let's see here. Turn off camera. I don't want to do that. All right. You guys have it. Oh, wait a minute. There we go. How about we do this? Up. Did that help?
Perfect.
Turned off my screen share. Did that help? Yeah? Okay. Great. Good morning. Okay. So let's just talk about general impressions. Does anybody have any comments about the first article that we're going to discuss? Come on, you guys. I know it's early. Number one, did you like it? Come on, Teresa. You look like you have something to say. All right. I'll make a comment. Okay, I know this is kind of the very first journal club that we've had, and this is a very generalized question. The first thing generally I do when I look at studies is it relevant? Okay, is it significant to the clinical aspect of it? Is it answering a question that I have? And I think that this is relevant. And the one reason I think that it's relevant is that in the emergency service, we see a lot of patients that have hemoabdomens from bleeding splenic tumors, right? So I like the fact that it was relevant. Um, I thought they did a pretty good job trying to extract information from the database, and I kind of, there was one graph, some of their graphs and tables, okay, but there was one graph that I really liked, a couple of them that I liked, and we can talk about that. So let's go ahead and move forward. You guys are a quiet group today. Let's go through, so since we don't have a lot of general comments, let's just start and go through this in an analysis. So I don't know how many of you have attended like official journal club rounds and or traditional journal club rounds. And generally when we do this, you start with you go through each section, and you start with the abstract, and then you go to the introduction and the methods and materials and results, and you kind of give ideas, comments, likes and dislikes about every section. And then at the end you summarize all that. So one of the things about abstracts is they should be able to stand on their own. When you read an abstract, you should be able to tell everything pretty much about the study in a Reader's Digest version, and it should stand alone. And one of the things I usually look for in an abstract is, do they have a concise, clear clinical question under the objective section? And under conclusions, do they actually answer the question that they posed? So if you look at this, they wanted to determine survival times for dogs with splenic hemangiosarcoma, but treated in 3 different ways: with surgery alone, and with chemotherapy, and they actually included 2 different types of chemotherapy, and they wanted to identify potential prognostic factors. And in the conclusion, they talk about clinical stage being the most strongly associated prognosis. That's a prognostic factor. They talked about chemotherapy prolonging survival time. That was kind of an answer. And they compared their 2 different kind of chemotherapies. And in the end, they said prolongation times, or prolongation survival times, resulting from current protocols were modest. So I kind of think they probably answered their objectives. Would you all agree? Yes. Okay. So I'm going to go to the screen share thing. Do you remember the 4 articles that I sent you from JABMA? Do you remember those? Somebody speak up.
The statistical ones?
Yeah, the what now?
The like data analysis ones?
Yeah. Yeah. Did you remember that? Okay. So what I did was I went through those 4 articles, and I made myself a document kind of pulling out the important clinical features or clinical recommendations for evaluating literature, and kind of put them down in a Word page. And then I kind of created this very short PowerPoint to just start. It's not all the information, but it's kind of a starting place. And the reason I did that is because I am not a statistical guru. In fact, I know very few veterinarians that are. And when I read a paper, I just get kind of bogged down in the statistics. And when I try to critically evaluate a piece of literature, I get a little lost. And in all honesty, I have not had any formal training in how to do this. I've just kind of participated in rounds and journal club rounds and kind of just picked it up. So what I liked about those 4 papers is, number one, it clearly states that you don't have to be a statistical guru to determine relevance and to look at a study, and that I found very appealing. So what I want to introduce to you is what's in those pieces of those different articles, and see if we can actually start to clinically apply those to the articles that we read, so that we can determine some things about them besides just the kind of information and conclusions that they give us. So this is the 5-step method that they highlight in one of the papers. in order to evaluate the literature. So the first one is to determine clinical relevance. So if you're out in the world, whether you're a GP or an emergency doctor or a resident or whatever, you don't want to waste your time reading articles that are not relevant, and you don't want to waste your time reading articles that are not well designed. So the first thing is you have to determine whether this is an article that will be useful to you, and that's what it means by clinical relevance. Have any of you heard about PICO? Have you ever heard that acronym? Yes, no, I can't see you.
No.
Okay, so PICO stands for Population Intervention Control or Comparison and Outcome. So the first thing you do with PICO is you determine the population. And if we look at this first paper, the population of dogs that they used were ones that presented to a tertiary hospital. I believe this article came out of Tufts. And so that's the population. And these dogs were diagnosed with splenic tumors, right? So I think the population is relevant. The intervention is pretty clear. They divided them up based on when they did their retrospective analysis into patients that were treated with surgery alone, those were treated with chemo, and the ones that were treated with chemo, one versus the other versus a combination. There was no control. I guess, in other words, I guess the control would be patients that didn't get anything. They were diagnosed, kind of like the second paper, but they didn't have surgery or anything, but they did not include a control, which I think is a problem with this paper. And then the outcomes are in your conclusions, and they made some very vague statements about, well, one was very strong. Clinical stage is associated with prognosis, number one. Number two, that chemotherapy was effective in prolonging survival time during the early portion of follow-up. The combination appeared to be a little bit more effective, but then they put this disclaimer at the end that prolongations in survival times were modest at best. So that's your PICO, and that's how you determine relevance. And most of it, often this can be obtained from the abstract. So if you read that and you do a PICO on it, and it seems kind of wishy-washy, or the outcomes aren't consistent with the objective, then you can theoretically, or actually objectively, you can put that paper aside and go on to another paper to answer your clinical relevance. Then the next thing is that you go to the study results section. You don't read anything else, you go straight to the study results. And I have to be honest with you, previously, that's the section I least wanted to read. Do you guys get that? Right? It seems to be so bogged down in statistics, and it seems to be, quote unquote, relatively boring, that when I saw that, I went, great. Last section I want to read. But I like the fact that they say start with graphs and tables. So you don't have to read the results section, but you start with graphs and tables. So if you will turn to, let's see, the first draft is going to be on page 396, and it talks about dogs that were treated with surgery alone. Okay? And if you look at that graph, it's a Kaplan-Meier survival curve, and I kind of had to do a little research on interpreting these because, like I said, I'm not a statistical guru. So the one on the left talks about surgery alone, and it's just a survival curve. So you've got your months on the bottom, and you've got your percentages of dogs alive. So 0 is 100, and then it drops fairly precipitously between, it looks like, about 3 months and somewhere around 12 months. Can you see that? Everybody see it?
Yeah.
Okay. And on the right-hand side, they divided these dogs that had surgery alone into stages. Now, if you read the actual methods section, I thought that was really nice. There's various ways to stage hemangiosarcoma, but these people chose to use a modified World Health Organization, WHO, where stage 1, can you guys find that? Did you find that in your the section? I don't want to have to read it off to you. So If you look on page 394, under Material and Methods, right-hand column, last paragraph, it talks about clinical stages at the time of surgery were assigned on the WHO scheme. So stage 1 is hemangiosarcoma, 394, confined to the spleen. 2 is splenic hemangiosarcoma that had ruptured, and 3 was clinically detectable metastasis or concurrent right atrial mass at the time. That makes sense to everybody?
Yep.
So if you look at that Kaplan-Meier graph that's on page 396, you look at that 1, 2, and 3, that's what it means. And you know, it's really kind of a duh moment for me when I looked and I said, okay, stage 1 lived the longest. And if you look, they lived almost 2 years. And that's stage 1, surgery alone. You look at stage 2, and although their survival decreased fairly precipitously until about 12 months or so, they also had a handful of patients. So these are ruptured spleens that lasted out until almost 2 years, just like surgery alone. And not unsurprisingly, stage 3 got about a year at best, but fairly precipitous drop for 6 months, and then just some stragglers that lasted another 6 months. Does that make sense?
Mm-hmm.
Okay. So then under the results section, if you go to the next graph, and I'm going to have to tell you, I've got to dig deeper on this. Actually, the next table is table 1, and it talks about univariate analysis of factors potentially associated with survival time. And really, basically what all this tells you is that it's related to clinical stage, what we just went over. That's basically what it tells you. And that's that they're talking surgery alone for both of these. And the bottom line is, if you've got a 1, you live longer. If you're a stage 3, you live a lot less. Make sense? Yeah? Yeah? Okay. Then the next one under results is on page 398. And that's another Kaplan-Meier curve, but it looks at the dogs treated with surgery alone, which was the majority, 120, and then the 54 dogs that received any type of chemotherapy after their splenectomy. And that's on the right-hand side on the A graph. Does anybody want to make a comment on the appearance of that graph? What do you see?
Not much difference, it doesn't look like.
Thank you. Okay. Now, I think that if you're a little bit more critical at your looking at this graph, you will see that the red line, the chemotherapy dogs, in the first 4 months had a higher percentage of them surviving. That blue line dips pretty quickly, but that red line has although a fairly steep slope. You can see in the first 4 months the chemo patients, and they're not separated out into the type of chemo, but you can see that there's a little bit more, right? So if you look at graph B, you will see that these, the blue line still is the surgery alone, but the brown, I guess green and red ones are divided into dogs that got the different kinds of chemo, right? So if you look at the brown line, those were metronomic alone. If you look at the green line, that's conventional doxorubicin-based alone. And then if you look at the red line, that's a combination. Now, when you look at that, what do you see? Andrew, you popped up before. What do you see when you look at that graph?
Well, unfortunately, we're looking at a black and white graph over here.
Oh, that doesn't help. So if you will look at the one that kind of stair steps out and then drops precipitously, the one that's farthest to the right, that's your combination chemo.
Okay.
So, and then the 2 lines that are kind of overlapping in the middle, those are your either one or other.
Okay.
And then, of course, your blue line looks just exactly like the one on the left. And so when I see that, there looks like in the first, again, 4 months, there's a little bit of the shift of the line to the right on the combination, and on the individuals, and a little bit more shift to the right on the combination, but none of it makes any difference after 4 months, right? Okay. Then if you look at the table under the results, I find it a little bit confusing. It talks about the difference between surgery alone and the combination of dogs that received adjuvant therapy. Okay, and I'm not really good at interpreting those. That's actually on my list for the next time we do that. I'm much better with just graphs. So we will hold interpreting some of those tables until the next time we do that. On page 399, you have your last Kaplan-Meier curve, duration of chemotherapy and survival times for all types of chemo. They're not divided out. So if you look at your green line, that's the duration that these dogs actually got chemotherapy, which is the shorter line, the one closer to the y-axis. And if the other line that goes out a little bit further is actually their survival time. So I didn't see much of an explanation of why these dogs didn't get chemotherapy for an extended period of time. But if you can see, the slope of those initial two lines are pretty much the same. Chemo stops on an average somewhere around, looks like 12 months. But the survival times of some of these dogs, these are all dogs, went out as far as 2 years. A handful. All right, so when it comes to recommendations for look at, the next thing that we're supposed to do is examine bias and confounding. Oh, let's go back. So there's types of studies in order of weight. In other words, how much weight do we give to their validity? And you'll see at the top is systematic reviews and meta-analysis. I'll come back to that. Randomized controlled trials, observational studies, and then retrospective studies, of which retrospective is the one that we're looking at. So when you look at randomized controlled trials, all these trials have their pluses and their minuses. So if you do a randomized controlled trial, it has the greatest degree of control of bias and confounding. I didn't type very well on this, but instead of doing so, it may yield results that are not directly applicable to natural situations. On the flip side, your observational studies are usually clinically applicable, but they lack rigorous control that could take care of factors that have bias or confounding. So let's talk a little bit about bias, because that's kind of the section we are on our 5-step. So there's your definition of bias. Oh, let me back up. Nope, this is just a statement about bias. So when you're reading a study and you're interpreting it, we all have pre-existing beliefs, right? We all come to the table with our thought processes based on our training and previous reading and even experience. And that can sometimes influence how much you believe the results of a given study. And it doesn't matter how good the study is. Some of us will still be doubtful, and you'll run across other clinicians that are still doubtful despite how good the study looks. It's okay for that to happen, but you have to take a step back and look at the reason why you have those beliefs. If your pre-existing beliefs are based on valid information and critical thinking, then that's really acceptable and valid. But if your beliefs are just heirloom knowledge, that stuff that's kind of just handed down to us as we go through school and as we go through our post-school training, then that can be problematic. Let's look at an example of heirloom knowledge, shall we? How about don't give acepromazine to a seizing patient, right? We were all taught that at one point or another. That's really since been disproven. Let's talk about giving famotidine IV to cats because it might potentially cause hemolysis. Davis did a very nice study on that. So there's some heirloom knowledge that gets passed down to us that's not always valid. So here's your definition of bias. Basically, it's prejudice. That can be in favor of or against. And it's usually considered to be unfair. And then there's lots and lots of types of selection biases. Oh my gosh. But not selection, but biases in general. We're just going to look at 3 or 4. One's selection. And you have to pay attention to this in these studies. And that's if you're different groups of animals, if your animals differ in their groups in more ways than just the intervention. Information bias, you can read that. It depends on if one group, certain subjects are observed more closely, have a different kind of monitoring, or they're observed for longer periods of time. Confounding, 2 or more factors are associated with each other, but not evenly distributed, so you can't determine which is really associated with your outcome. Wish bias, I kind of like this. It's also considered or known as optimism error. And the problem with wish bias usually comes into play when you have unblinded assessors. Because if if your assessors are unblinded, it has been proven actually scientifically that they will identify fewer treatment failures. And then I think this one is huge, publication bias. I think that I agree that there are some articles that are some studies that are simply not reported. And they're not even submitted for publication because they either haven't found an effect or they've found an effect that is contrary to what they want. The other thing that I will interject here in terms of publication bias is that systematic reviews and meta-analyses are held at the highest hierarchy of trials, right, or reviews. It's considered to be our best evidence-based medicine. But the problem with that are the trials that the people select to analyze, systematically review, or meta-analyze. The trials that they pick have to be really good, rigorous, well-designed, well-administered trials. So when you read a systematic review or a meta-analysis, and they're starting to become more prevalent in veterinary medicine, if you're really going to do a good job of taking what they say at face value, you need to actually look at the studies that they use to develop their systematic review. Now, I've already sent Andrew a podcast that addresses that. Did you get to listen to that Newman podcast, Andrew?
Yeah, very entertaining.
Yeah, it was very entertaining and very informative, was it not?
Yeah.
So what I intend to do for the rest of the group is I will now forward the rest of you this one podcast by David Newman. He's a human physician and a big evidence-based medicine guy, and he talks about the inherent fallacies or the problems that can be involved with systematic reviews and meta-analyses. So that was an eye-opener for me, and I think you will find it not only entertaining but quite informational. So the last thing I want to talk about in veterinary medicine is that when you have a clinical question, and this I'm trying to do all this for when you guys are outside the internship program, it's not always possible to find these great randomized, double-blind, well-conducted studies, and multiple ones at that, to answer your clinical question. I.e., if I have this dog come in with hemangiosarcoma and a hemoabdomen, and I can only identify a splenic mass on abdominal ultrasound, I don't see any mets, the chest is clear, what do I tell these owners? Or let's say it looks like there's mets in the liver, or whatever. What do I tell these owners? How do I go about treating them? Do I recommend chemo? Do I not recommend chemo? And we do a lit search, and we come up with multiple articles, and the one that we see is this one, okay? Maybe the only article we find is this one, and it's a retrospective study. Sometimes that's what we have to deal with, but we really have to be careful, and I think a lot of us are at fault. A lot of us, even as senior clinicians, are at fault. We have to interpret those results, as it says, within the limits of the study, and we really have to be careful to avoid extrapolation beyond the study population. A big example is, well, this medicine worked in dogs, maybe it'll work in cats, right? It's really difficult to extrapolate that information, and we would surely need to be wary of doing that. All right, now, going back to, sorry about that. So going back to, I'm going to take and get out of this for right now, sorry. And we're going to go back and look at the bias in this paper, okay? So, selection bias, information bias, wish error, wish bias, optimism error. So, what do you think? You guys got any comments about whether or not this might be a biased thing? Do you see any place where there might be bias introduced in this?
I mean, there's.
So let's look at the study groups. Let's look at the study groups. Let's talk about that. They were divided into 1s, 2s, and 3s. Okay, and it looks like they all, as far as the study group themselves, it looks like they all got the same baseline evaluation in order to be divided into their groups. I think that where I have a little bit of issue about where this study was conducted is they post-analysis went back and analyzed the data for the combination chemotherapy. Did you see that? That was not in their original analysis, but if you look, I think it's under the discussion. Let me go back here. That's the only thing that really bothers me, because supposedly, and I've just been doing a lot of listening and reading, supposedly when you determine a study, you do a clinical question, you go back and you determine what questions you're going to answer, you determine the analysis you're going to use, and you do that, and you get a certain set of data or results, and then you kind of look at it, and then you go back and you analyze it a little bit differently, or you use additional analysis. So if you'll look at this particular study, let me find here where it is. There, oh, there's another one I thought I was a little bit concerned about. We'll come back to it. Okay. All right, it talks about here that the statistical methodology used to analyze the effect of the adjuvant chemotherapy on survival time study differed in two respects from the methodology typically used in veterinary studies. So not only did they get their initial data and then went back and did a sub-analysis if they would, although they went back and did a sub-analysis, the method that they used for their sub-analysis of one chemotherapy versus another chemotherapy versus the combination chemotherapy, they clearly admit was different than the ones that are typically used. And that kind of raised a little red flag for me. And not being a statistical guru, I can't look and say, oh, well, that's really weird. That's really inappropriate, or I get it. But that one statement under discussion kind of made me a little hesitant. The other thing that they did was they excluded dogs that didn't survive 15 days from their analysis. And they excluded those dogs because they didn't start the chemotherapy until 15 days, and they wanted the entire group to have a mean survival time that was consistent between the two groups. So excluding those 15 that didn't die, or that did die within 15 days, makes a difference on your analysis. So that kind of machinations kind of gave me a little bit of pause at looking at it. And that's in the discussion. It's on page 400 if you would like to review that for yourself. So that kind of going back and doing that kind of bothered me a little bit. The other thing, there's one more thing. I should have mentioned it then. So when they went back and they did this comparison between one chemo, other chemo, both chemos, they came to the conclusion that chemotherapy had a beneficial effect in the first 4 months post-surgery and identification. But they didn't make any difference after the first 4 months, which I kind of go, really? You know, does that make that big a difference? And when I look at these graphs, I go, that doesn't look like that big a difference to me. And there's a statement under, I think, the results section that it says, among dogs that received both types of chemotherapy, the dog that survived the longest died of hemangiosarcoma 13.4 months after the initiation. So the longest survival time they got with chemotherapy was 13.4 months. There were 4 dogs in the surgery alone group that lived greater than 2 years. And then the N numbers was pretty decent. It was 208 dogs. So I'm going, well, you know, I'm just not sure how convinced I am that their assessment of the combined chemotherapy is really that beneficial for these patients. You have the added expense and all that kind of good stuff. So that is pretty much where I came down on this particular paper. The other two factors in the 5-step program we're going to conclude in the next journal club. It talks about identifying the observational units, which means is it an individual dog, is it a group, is it a herd, and it also talks about statistics within those groups, and we're not going to go over that today. So I would ask you, Dr. Erickson, since you guys aren't answering very quickly or offering, I would ask you, Dr. Erickson, what would you do with this information, with this paper? What would you do with this information the next time you have a client come in with a dog that has stage 2 splenic hemangiosarcoma? In other words, has a hemangiosarcoma that has ruptured, but you can't find any other metastasis.
So
what would you tell those people? Pardon?
Study, you could say that stage 2 would be the most common stage to find them in, which we typically do see chemoabdomens. And as for surgery versus chemotherapy, we could, based off of the study, say, we have similar survival times with doing chemotherapy in addition to surgery, offer maybe a little bit more time, or at least a better quality of life for a longer period of time, and then use that to kind of help them decide if it was just surgery, their cost came into it. You could say, at least surgery, this will give them X amount of time.
Mm-hmm.
Or chemotherapy, we get maybe a little bit better quality of life for a longer period of time, or a longer survival time in addition to that.
Okay, and I agree, but you need that, couching that in May, right, is very appropriate, because I don't think we have definitive results based on this trial that chemotherapy definitively makes a difference. And I also think we have information based on this paper that the true benefit of chemotherapy seems to be in the first few months. First 4 months, right? If we're even going to accept what they say at all, it's like if you do chemotherapy, it has its best effect in the first 4 months, and it seems like more dogs survive longer in that first 4-month period of time if they have chemotherapy. You might even add that there is documentation that some dogs live extended periods of time. Well, I talked about stage 2, that they can live longer. They can live a long time. Let me back that up. Some dogs with surgery alone do quite well for the same length of time. Let's just put it that way. So now that we've done all of that, what do you guys think about? What do you think about the study, Schumacher?
I think it's a good start.
Okay.
And I think, obviously it has limitations just being a retrospective study, and they discuss that how in the future we need, controlled studies that aren't retrospective. They're actually, we control how we stage them clinically. So yeah, I think it's a good start, and I think they do a good job of discussing their limitations and kind of where we need to go from here.
I agree. I think the staging aspect was huge, because I typically don't prognosticate based on stage. Well, I guess I do, because most of the time, and I'm just being honest, most of the time if we find Mets, I go, right? I don't know this is a good idea to continue. Isn't that usually what we do? Yeah. If there's significant metastasis, don't we usually say this is not good? Their survival time is not long. So we do yes Mets, no Mets, but I never really looked at that in-between group, that stage 2 group where it's ruptured, and make a difference between no Mets, ruptured spleen versus Mets. So I kind of like that. I learned something from that, and that there is a little bit of difference in terms of survival time and prognosis when you take and stage them that way. So that's probably a bigger take home for me was this whole staging thing. Probably should have been doing it longer, not just yes or no, but that in-between group. All right, so let's look. We got a little bit of time left, not much. Let's kind of just briefly consider the second article, single-agent polysaccharidosis saccharopeptide delays metastasis and improves survival in naturally occurring hemangiosarcoma. Okay, so I thought this was a really, I'm just going to give you my impression to start with. I thought this was a really interesting article because I don't recall, at least in the veterinary literature, having seen much attempt, as far as veterinary herbal and homeopathic, much attempt to produce something that is more scientific in origin. I mean, have you guys ever run across something like this before? I haven't. I don't know about you guys, but I haven't. So my first impression was, oh, cool. You know, somebody's really trying to start doing this. So I thought from that perspective that it was very interesting. Did you notice where it was published? Evidence-based complementary and alternative medicine. I like that, evidence-based, because we just don't see much of that. And so I really applaud the author's attempts to try to give us this information. As Western-trained allopathic veterinarians, I think I really applaud them for doing this for us. So the abstract was just more of an introduction, condensed introduction. I got a little bit of a feeling for what their clinical question was, but I didn't get, and I got a little bit of a feeling for their outcome, but it wasn't really your classic abstract. So I couldn't just read this and get as much information out of it as I would your typically structured scientific literature like the one before. Okay, so that's just an observation. I'm not saying it's good or bad, but it's just an observation. So if we look, if we take in, what was our first step? Determine clinical relevance, right? Determine clinical relevance. So would anybody volunteer whether or not they think this is a relevant article?
I think it definitely has relevance as an alternative to offer people, but I don't think it really has data to back very much up yet.
Okay, fair enough. So I would tell you that I normally try to determine relevance from the abstract, and I actually couldn't from this one, other than, gosh, yeah, it's an alternative therapy, and that might be relevant. It piqued my curiosity, but I actually couldn't look at the abstract and either accept or decline like you can with some other ones. So the next thing it says is to go to the results, right? That's what our thing says, and to look at charts and tables. So I found under the results section, okay, they give me the amino acids and the protein proportions. They give me days to progression of abdominal metastasis for the 15 dogs, okay? And you can see that the one that got the higher dose had more days for progression, okay, that said that. And then the other one is table 2 is just baseline characteristics, which it looks like they did a pretty good job. If you look at the age and the sex and metastatic disease present at enrollment and all of that, it looks like they did a pretty good job of matching their study groups, which is really important, right? That avoids a selection bias, okay? So they did a pretty good job of matching their study groups in terms of mixed breed, sex and time from diagnosis to study enrollment. All those things were fairly well matched, and that's really important. And then if you look at the table 3, that's just talking about what their what their blood parameters were, their blood work, and I think I just perused this. I think that's fairly well matched, but that's that. And then if you look at page 5, you have your more data. Yeah, this is your hematology. The other one was just serum chemistries, and if you look at that, they all seem fairly well matched. So there's a lot of information there showing that between these 3 groups, these animals were fairly well matched, and that's really, really important for your selection bias. And then I think I found the thing that was most interesting was figure 2. So if you look at figure 2, it's the Kaplan-Meier survival curves for 15 dogs diagnosed, randomized into the 3 treatment groups. And that was just based on dosage. It also puts historical doxorubicin-treated hemangiosarcomas. So if you look, there's an O and an X on that graph, and the O is the shortest median survival time, and X is the longest median survival time reported in the literature. And although it doesn't state this, I believe they're comparing it to doxorubicin-based chemotherapy. It doesn't state it here under the figure, but I believe that's correct. So if you look at O, it looks like, shortest time is like 2 weeks. And if you look at X, it looks like the longest time is 86 days. It tells us right there. So 19 days and 86 days based on doxorubicin. So when was this written? You guys know when this was written? There we go. So this is written
2012.
March, received in March, revised in May, accepted in July 2012. So this was actually accepted in July 2012. So it just goes to show you how information can change, because that statement's no longer true based on the article we just read, right? In terms of survival times, the doxorubicin base, they had a much longer survival time, at least in the study that we just read. So I found that interesting. Okay, so if we look at this curve, we see that the very light dotted line is the 25, the heavy dotted line is the 50, and the solid line is 100. Well, when I was looking at this, I'm going, okay, the lower one, really interesting, the lower one drops off pretty quick to the point that you maybe have less than 25% of your dogs alive by day 75. That's on the 25 milligram. But don't you see how that line, once you get to that drop point, don't you see how that line extends out really far? Doesn't make any sense to me. Can you see that? Can you guys see that in your black and white paper? Can you see the little dotted line that represents the 25 milligram? Yeah? No?
Yes.
Yep.
Yes. Sorry.
So doesn't it look like it gets down below 25% and then it extends horizontally out past 700 days and then drops down? That's weird. 700 days? That's like almost 2 years. And then if you look at the heavy dotted line, it drops down faster than the 100. That's the 50. It drops down to about the same level, about 25%. And then it goes out past the 100 to like 430 or 4 something, it looks like, days. And then you get your solid line that doesn't drop as precipitously. I mean, it looks like you still have over 50% of them alive at 200 days. But then it stops at like 360 or something. So I don't get the way this graph looks and what they're reporting in the literature. I'm either reading it wrong, but this graph to me is not consistent with, at least I don't think it's consistent with what they're reporting in their article. So I may simply be reading it wrong, but to me it looks like the ones that got the lowest dose lived the longest. Although they dropped off quick, a high percentage of them dropped off quick, it looks like they lived longer. And that's not the conclusions that they came up with, right?
It's an N of 5, right? N
So
of
it's
5.
15, N of 15 total.
Yeah, but
So what if we had one dog that lived 2 years? Well, in the other paper, we had 4 dogs that lived longer than 2 years.
yeah, but they had 200 dogs versus 15, so
Right, right. So I find this graph not supportive necessarily of what they were telling us in the article, or at least in the article it didn't bring this whole thing out, or I didn't perceive it. Maybe I didn't read it close enough. So that's one thing. So just looking at the graphs, this is the only one that meant a whole lot to me, and I found it somewhat confusing and a little misleading. So that's that. All right, so after we look at the results, after we looked at the results section and we look at our graphs, then we're supposed to evaluate for bias, right? what do you guys think about what they did to control bias in this particular study? Well, I will tell you it's probably one of the best ones I've seen in terms of that particular aspect of the way they did it. It was randomized, it was randomized, controlled, and it was blinded. If you guys read the material and methods, they computer generated who was supposed to get what, and that number went to the pharmacy, and the pharmacy made the capsules up and shipped it to the owner. All the capsules were made to look the same. And when it came to what drug they got, that was kept per number by the pharmacy as to what was distributed to them. So I thought their attempt to avoid bias and bias was huge. I thought they really, really did a super good job at controlling for bias. I was totally impressed. All right, as far as confounding goes, the one thing I did not see them do, which after reading the first article, one thing I did not see them do was stage these patients and put them in stage 1, 2, and 3 with the various types of thing. Because we know from the article we just read that based on conventional allopathic medicine, surgery alone versus chemo plus or minus both, that had a that had a little bit of a difference, and I didn't see them stage those dogs to see if maybe the ones that were stage 1 were actually getting the 100 milligram, right? Maybe the ones that were stage 3 were getting the 50. Do you see what I'm saying? They did have evidence. They did in here in a table point out, when they were looking at the study groups and how they were proportioning the study groups, there's a little bit of staging there. That's it. So if you look on page 4, it talks about at the bottom metastatic disease present in enrollment, 2 no, 3 yes, and then progression of their metastatic disease. But they didn't really tell us that what did the ones that didn't have metastatic disease, how did they do? Because we know they live longer, right? We know ones live longer. So how did they do? And they didn't break that down for us. They didn't tell us, okay, the ones that had no metastatic disease, they didn't develop progression until XYZ, okay? Or the ones with metastatic disease developed progression at XYZ. So that's the only thing that I thought was a little confounding, is that we don't know how these dogs without and with, at least I didn't pull it out, did with results to the Unibio. Not Unibio, sorry, high immunity. So I would ask you, Cassie made a comment, earlier about the study in general. What if you had a client? Here's another scenario, and I guess I'm going to pick on Andrew. If you had a patient that came in with a hemangiosarcoma, and let's say there was a mild hemoabdomen, dog had stopped bleeding, fairly stable, little fluid therapy, was looking great. What would you tell these owners in the light of both of these articles now? Okay, how would you kind of put these two together to educate your client?
Well, after looking at this article, honestly, I probably would not bring up this product unless the owner brought it up.
Okay.
Medication, unless the owner brought it up, because I don't know that it's necessary to educate the owner looking at this, knowing that we're really not seeing much difference at all compared to our surgery alone and our
chemo.
Excuse me, or just surgery alone methods.
Okay. Anybody else have a different opinion? Cassie?
I mean, I guess it depends on the owner. I mean,
Sure. Okay.
I mean, it's something I think that you could mention. Erickson was mentioning Greg's used it in a patient, and this is a ridiculously expensive medication.
Yeah, that was one thing I was going to bring up as well. Yes, go ahead.
I feel as if most owners that would do this medication would also be game for doing everything else as well.
Fair enough.
the cost of it.
I think that's very fair. So one of the things, and I'm glad you brought it up, Cassie, and I was going to bring it up subsequent to our discussion, is this is an outrageously expensive drug. I can't remember, it was a couple of $200 or $300 a month
I think it's two.
for your average spleen dog, which is generally a larger dog, right? 45 to 85 pounds. So it is quite expensive. And, you know, if the owners didn't want to do anything at all, they didn't want to do anything at all, but they wanted to know, is there anything I can do? I don't want to do surgery. I don't want to give chemotherapy. Is there anything I can do? I might be inclined to tell them about this, but I also would have to tell them that this is just a pilot study, that the N numbers aren't large enough, that there hasn't been any comparison studies between conventional therapy and this, and that I really don't know how much it's going to help. But if you want to do something, but not conventional, I think I would probably mention it. If I had a patient that was, if I had a client that was like totally all out, right? Want to do chemotherapy, want to do surgery, want to do everything and anything, I might mention it to them too. Do you know what I'm saying?
Oh, yeah.
I would hate that kind of all-in client to do some Google, talk to Dr. Google, right? And find this and not have been educated on it, right?
I do like added chemistry, so you can compare and say, you know, what side effects do we see, what biochemical markers do we see as this has gone on. So
exactly. So in those two situations, I might introduce this concept. I can't do anything. I can't do it. I don't want to do any of the other, but I want to do something. Or in clients who will take their dog anywhere it needs to go to get any kind of therapy, I would probably let them know that this exists. But I wouldn't be able to say, yeah, this is great, it's going to make a huge difference. I would have to say there's only been a pilot study down and there were some modest favorable response, but we don't know. Does that make sense? Okay. All right. So I kind of like this virtual thing, don't you? Yeah. I kind of like sitting at my desk, office, and drinking my coffee. So would you guys like to try to do this again in the future?
Yeah, definitely.
Okay. All right. Now, does anybody have any comments about the two articles that we've read? All right. So we won't be doing this again for a few months, but I would encourage you to review those papers that I sent you, those 4 papers that I sent you. It's going to be really, really important when you get out of your internship, regardless of what you're doing, that you have the ability to look up the literature to answer a question or look up the newest stuff that's available and be able to think critically, to be able to look at this paper and say, is it relevant to the clinical decision? And if it is relevant, how good is the study? And then be able to make your own assessment about whether or not you're going to do things differently, you're going to include it in your client education, or you aren't. It's just super important. And I've always found it difficult to do, mainly from the statistics part, but this seems to be a fairly reasonable way of approaching it. So I would encourage you to look over those. The last thing I'm going to mention is likelihood ratios. Those are applicable to new interventions, testing primarily. Okay, so a positive likelihood ratio that's high enough indicates that if it's a positive test, most likely the patient has this disease. Negative likelihood ratio, if it's high enough or actually low enough, indicates if the test is negative, this patient most likely does not have the disease. One of the things that I've noticed in veterinary literature is that the authors very rarely give you likelihood ratios. And so I looked up how to calculate them. It's super easy. It's on the internet. The only information you need from the paper is sensitivity and specificity, which we get a lot. We get a lot of sensitivity and specificity in our papers. So you can just Google likelihood ratios and get the formula yourself. And when it comes to looking at articles in the future that are regarding a specific test or a specific therapeutic intervention, well, mainly a test. Let's stop there. A specific test, then you can use your likelihood ratios to get a really good idea of whether or not this is a good thing to do or if it's something maybe not so useful. So there is also another podcast on likelihood ratios that I will send you. It's by the Phonecast group, Westifer and Jeremy Faust. So I'm going to send you 2 podcasts, David Newman talking about meta-analyses and systematic reviews, and Westifer and Faust talking about likelihood ratios. Okay? And you guys can listen to those at your leisure. They really won't be important until we sit down and do our next virtual journal club. Do you guys have the list of the rounds that are scheduled for the next several weeks? You guys all got those?
Mm-hmm.
Okay. All right. Well, I guess that's it. We're done for today. Thanks for the participation. I really appreciate it. And I'll let you know if we're going to put it up on the website or not.
Okay.
All right. Bye-bye.
Bye.
See you later.